All right, well, good afternoon. My name is Leon Scott. I'm one of the physicians with the Department of Orthopedics. I'm honored to be able to give this talk to you during the Foundations of Healthcare Delivery lecture series. My lecture is actually going to be on healthcare finance, and I want to give you a clinician's clinical spin on an administrative topic. I hope you find this information useful as you're moving forward as a student, but also in your future practices. All right. I have no disclosures to make, and the objectives will be to help create a familiarity with how medical offices get paid, how people pay for those services, and hopefully give you some practical tools so you can have a positive impact on the patients you're serving and the organizations that you're working for, so that you can deliver great care and not put people in positions necessarily that are difficult for them to manage financially. Excellent. I want to start with this quote: "Our business is service. It is the task of finance to make service profitable." And this is from Theodore Vail. He was the former president, CEO of the Alexander Graham Bell Telephone Company in the 1910s. And he was a revolutionary in that he wanted to make sure that the true purpose of a company was what was the focus, and not just making money, as revolutionary as that may sound back in the 1910s. So I hope this is just a reminder to every one of you that although we're learning about healthcare finance, our purpose is to provide great healthcare to our patients and to hold the business people of our organizations accountable to that task. The focus is on giving great health care. We need to be creative in finding ways to finance that and make it work, but we should always be able to provide great health care and not feel like we're limiting great health care from certain people. All righty. So what is finance? Finance is the practice of money management, and as a verb, it is providing funding for something, okay? Healthcare transactions. We're providing funding for healthcare transactions. Well, what does that word mean, especially transactions? What does that mean? Well, a transaction is just the exchange of money or credit for a good or service. And all the buyers and sellers of goods and services, these different transactions in the healthcare space, make up the healthcare market. And as you can imagine, this is a vast network and web of different buyers and sellers of services. But let's make sure we keep our focus clear. Our focus is on the individual and patient who is trying to get healthcare services from a provider, in this case noted as hospital. And there are different services that help support the patient in being able to finance that when they're needed. So if we think about it from a personal level, how do you pay for the goods and services of healthcare? Well, you use money, ultimately, right? And what is money? And this is a simplified version of essentially a person's personal cash flow statement. Well, you have your income minus what you have to spend on your income on bills or putting money away for investments. So that's the money you have left over. At this moment, the money I have is the money I earned minus what I had to pay for or put away for investing. That's what's currently available to me. We also, oh yes, before we get into that, what's very interesting about the money that people have is how little of it many people have put away. So according to Yahoo Finance in 2019, about 45% of the population doesn't have anything put away. They don't have any dollars to pull out in case of emergency. Less than, or about 24% have less than $1,000. So less than 69% have $1,000 to spend on emergency issues. Notice in red the 10,000 plus, and I put that in red so it would hopefully stand out. as far as family deductibles go, we'll talk more about that in a little bit. The deductible is the part of the insurance that you pay before anything else is added to the payment of healthcare services from your insurance company. And the average family deductible is quickly reaching close to $10,000. So only approximately 15% of the population is estimated to have that much available to cover a deductible in case something were to come up. So if we don't have enough money, what else can we use to pay for healthcare goods and services? Well, we can use credit, and we can use credit lines, like secured credit lines, a second mortgage on your house, okay. Unsecured credit lines, like credit cards, okay, that's available to us. And then insurance, which is not technically credit. I understand it's not technically credit. It is a group of people who will provide funding to you if you've been paying in. So in a way, it's kind of like credit. There's a certain amount of money you may need, and that can be added to you, to your payments for healthcare services, and it isn't necessarily money you already had ready to go. So grouping it in that credit section there. Before going any further, I want to talk a little bit more about insurance. Know that people use insurance to get healthcare, and I want to give everyone listening a little history lesson on where insurance in the United States came from, healthcare insurance specifically. All right, so back in the 1890s, the predecessors of health insurance were these groups of doctors that would get requested by manufacturing companies, logging companies to take care of their workers. So the companies would pay a certain amount and say, hey, can you just take care of things as they pop up, injuries and accidents? And because these were dangerous professions, and because some of the more established treatments were surgical treatments, and there were antiseptic techniques to help care for people after surgeries like amputations. It was useful for these companies to employ, or at least pay a lump sum to physician groups who would then take care of them, kind of like a team doctor. Then in the 1920s, a group out of Texas saw that, well, some healthcare services happen unexpectedly to people and are expensive, like surgeries because of accidents. And if you go to a hospital, it could pretty much bankrupt some families. So an organization, a nonprofit, was developed, which became Blue Cross. That nonprofit said that to the Texas Teachers Guild, I believe, if your members pay us $90, the equivalent today, in today's dollars is $90 per year, we will cover a 21-day hospital stay for the families of the teachers in this guild. A 21-day hospital stay back in the 1920s would be equivalent to $7,900 today. Now, they were not necessarily private rooms, and they didn't have flat screen TVs. Today's hospital beds, if you were in one for 21 days, would run you about $30,000 to $50,000. And not horribly much more expensive. Although it is more expensive, but not horribly so, considering now we have private rooms and flat screen TVs and a number of different amenities. But still, that amount could bankrupt people. So Blue Cross was developed in order to help cover those costs for people who paid in. So if we think about the types of things insurance was covering, if we look at it on a matrix, it was ready to take care of unpredictable and expensive treatments like surgeries or accidents. And today's healthcare, that also can include things like cancer. We have an unexpected cancer diagnosis that pops up that will be expensive to treat. So that's what the initial insurance, initially insurance was structured to cover. Then in the 1930s, there were advances in medicine. The development of antibiotics, vaccines started coming into play, ventilators, IV anesthetics. Now we could take care of patients for longer in the hospital, take care of more things in the hospital, and even see people as outpatients. So in 1939, Blue Shield was developed, a nonprofit that covered outpatient medical care. So now we're starting to see that insurance is growing, with the ability to cover not just unpredictable expensive things, but unpredictable, relatively inexpensive things like a respiratory illness if you have community-acquired pneumonia, or predictable, inexpensive things like annual exams and vaccines. As we move forward into the 1940s, about 10% of the population had health insurance. Then in 1941, World War II happened, or at least the United States became engaged in World War II actively. In 1942, the Stabilization Act said that salaries were to be frozen. But if you wanted to add benefits to employees, packages, you could do that in the form of pensions or in the form of healthcare insurance. Then also in 1942, the Revenue Act was enacted, an act that said that businesses that made more profits during war times would have to be taxed significantly higher on those additional profits compared to their previous earnings. So it was to the companies, and they were incentivized to actually push their profits into benefits for employees. So they started bolstering healthcare insurance and pensions. It just so happened that those were tax-free contributions. The employers, if paying a salary to an employee, yes, the employees have a portion of their salary taxed, but currently 7.6% of your salary is also taxed to the employer. So to have something like healthcare insurance where you could put money into it tax-free was seen as a benefit. So in 1943, there was actually a court ruling that confirmed that indeed healthcare insurance contributions from a company was in fact a tax-free contribution. Well, healthcare advances continued. There were advances in intensive care units, more vaccines came to play, and eventually companies like Aetna and a company that eventually became Cigna said, well, there may be money in this. We will be for-profit companies, not nonprofit companies like the Blues, and we will have a business model where we can provide healthcare insurance and help tap into employers' contributions, but we're really going to focus on healthier groups. We're going to do as much as we can to take care of the healthiest part of the U.S. population. So this was the beginning of the commercialization of healthcare insurance, and the Blues converted to becoming for-profit as well over time. In 1954, the tax code was preserved so as to preserve the tax-free contribution benefit that employers could make into their employees' benefits package. And by the 60s, 80%, up from 10% of the American population under age 65 was covered by employer-based health insurance. In 1965, Medicare and Medicaid were enacted into law, and now the large majority of U.S. citizens were covered by healthcare insurance. Now, there are, of course, things that happened since then. In the 90s, you have health maintenance organizations, and recently we had the ACA and AHCA. So there have been a lot of things that have happened to insurance since that time. But at that point in time, in 1965, our expectations for healthcare insurance changed. unlike insurance for your car, now we wanted healthcare insurance to cover everything, not just the unpredictable, expensive things, but even the predictable, relatively inexpensive things and the predictable, expensive things. So just a table of some of the items that we now provide in our current healthcare system that are expected to be covered by insurance when that wasn't the initial intent. Now, what this has done, at least in my opinion, we have a certain amount of money that we can spend. We have a certain credit limit that everyone will individually reach based on income and different assets. But the insurance part of this equation has grown where now we don't just expect some coverage for some things, we expect never-ending cascade of money to cover all of our healthcare needs. Now, if money is able to pop up out of nowhere and be deemed valuable and not influenced by inflation, hey, why not? But we have to be aware that ultimately this money all comes from somewhere, and ultimately it all comes from you. You're paying for subsidized federal insurance through your taxes. You're paying ultimately for your insurance through your work. You're either not going to get, not going to have a bonus and a certain salary because part of that salary is being placed into your benefits package. So ultimately, you are paying for this. It doesn't just come out of thin air. That isn't necessarily a bad thing if we can afford it, though, which brings up two topics that I haven't yet addressed regarding insurance. The first of which is that health insurance, as it is currently constituted, encourages healthcare prices to rise. Based on all the things that we want health insurance to cover, it just by virtue of how it works, encourages that the healthcare prices to go up. And let's talk about that before we jump into the second topic about insurance that I haven't touched on yet. So how is it that health insurance can encourage prices to rise? Well, first off is that the people who pay for health insurance don't realize how much they're paying for. For example, patients don't immediately feel the weight of healthcare prices, and that's because it's deferred. In fact, the Congressional Budget Office once made this quote, excuse me, health insurance causes people to care little about the cost of healthcare because they pay few or none of the cost directly when they get sick. In addition to that, employers who help funnel the money that you would otherwise earn into these benefits, they are kind of cloaked to a growing expense of healthcare prices because they are looking at the possibility of having a tax break. Let's look at this in a little bit more detail. Look to the far left, and there's an example of a starting salary for a middle manager somewhere, $58,000. At HC's healthcare benefits, let's imagine that person gets $0 in healthcare benefits, $58,000 salary. You see the taxes term underneath there, that 4.4K, that $4,400? That's not their income tax. That's the tax that an employer pays on top of the salary they're paying you. That's not their taxes on earnings. That's an additional 7.65% tax that employers pay just to pay their employees. You may not have known that that exists, but it does. And employers don't like that. So how can they decrease that? Well, in 2016, as an example, they could have said, well, the starting salary for this position is actually $40,000, and we put $18,000 into your healthcare benefits. And why would they do that? Because again, that $18,000 is tax-free. So they're only taxed as employers on the $40,000 that they're contributing, and that is approximately $3,000. So the HR departments are thinking, oh, great, we just saved $1,400 in taxes on every single employee. Or employees making this amount. So that becomes the positive reinforcement to continue to contribute to healthcare insurance and healthcare benefits. But something happens over time. And in fact, in 2017, the average increase in premiums for healthcare insurance increased by 3%. So in this example, that would be a required $18.5 thousand placed into healthcare benefits. Thankfully, to the HR director's eyes, we're still only getting taxed $3,000. It's okay to pay a little bit more in our healthcare benefits. But then in 2018, the increase in health care premiums went up 5%. So in this example, that would be $20,000 a year. And then in 2019 went up 4%. So that would go up to $21,000. So now, it's 2020 now, but in this example, in 2019, an HR director would say, man, we're paying $61,000 total in a compensation package for this position, $40,000 as salary, $21,000 as benefits. If we paid that all as salary, we would be taxed $4.7 or $4,700, and we're only getting taxed $3,000. Look at that, we saved $1,700 for this salary group. But what they forget is that 3 years prior, they were only paying $18,000 in healthcare benefits, and now they're paying $21,000. So although they may be paying $1,400 to $1,700 fewer in taxes, they're actually paying $3,000 more in healthcare premiums. And this goes hidden and cloaked to the HR departments of many companies. So part of the reason insurance it encourages healthcare prices to rise is because the people who pay for it don't see that they're paying for it. Patients who are in many cases employees and their companies don't see the weight and the pain of this growing expense. Well, also in current day, insurance companies have to pay a certain percentage of what they get in premiums out for healthcare services. I believe it's 85%. So if they're growing their bank accounts with growing premiums, well, we got to pay for something in order to keep our portion for ourselves. So they, in effect, incentivize hospitals and healthcare providers to order and purchase and use more expensive healthcare services so that they can pay out their required amount. More expensive care also unfortunately creates the illusion that people need insurance. So now, instead of identifying a fracture just through X-ray, if I think, well, I might need a CT scan to see the greater detail of this fracture, I am now moving forward in paying or recommending as a provider a more expensive care. And of course, if the doctor's recommending it and it's more expensive, I must need it, and I need a way to pay for it. And I couldn't afford a CT scan before, so thank goodness I have insurance, and they're now willing to pay out more. So there is this cycle that feeds on itself where insurance companies have to spend more, and of course, the more they spend on expensive services, the more insurance must be required. That's within the private sector. Within public and federally subsidized healthcare, the reason that insurance as it's currently constituted encourages healthcare prices to increase is because Medicare, especially with Part D, the part that pays for medications, it doesn't have negotiating power on what it pays. So the price also goes up because yeah, it can. Okay. All right. So insurance, health insurance, as it's currently constituted for all the things we want it to do, encourages prices to rise. There's another issue with insurance that needs to be addressed too. And we're only going to touch on this one briefly. And that's that if we want insurance to pay for things, we as a country need to identify what exactly it is it's going to pay for. We need to identify what ethic or principle or value US citizens are going to get behind when we design healthcare delivery. Are we going to design an actuarially fair process, which is to say, if I'm healthy and I choose healthy lifestyle choices, why should I have to pay for someone who has chosen unhealthy lifestyle choices? Makes sense. The other option is a community rated ethic, which says we're all in this together and we're going to each pay in the same amount. And to that one, you may say, yeah, that sounds great. Medicare does that. The VA system does that. Medicare for All, the idea tends to revolve around that. So you may say, yeah, that sounds perfect. And some may even say, no, that's not very American, even though the VA does it and Medicare is that way. But if you thought that it isn't very American, I just want to remind everyone that community rated healthcare insurance, at least, is something that almost all of us use. Employer-based insurance is community rated. If you are a fitness enthusiast and you're not a smoker and you always wear your seatbelt and you are employed at the same office with someone who may not enjoy a healthy diet, exercise, is a smoker, and doesn't like wearing their seatbelt, you both pay the same amount for your, and the same amount comes out of your paycheck for your premiums. So be aware that be aware that community rated approaches are quite American. So make sure you know exactly what you're talking about before you get into certain debates. And to that point, if you all are interested in reading more on healthcare insurance and the healthcare system, I encourage you to pick up these three books, Overcharged, Priced Out, and American Sickness. Priced Out is a great book to start with. It's written by Uwe Reinhardt and is a nice centralist view and an economist view that looks at both the conservative and more liberal sides of the argument. Overcharged is written by effectively a libertarian who has a very conservative approach. So I think that would be very helpful and illuminate some ideas for a lot of people. And then also American Sickness, a more liberal book. And ultimately, I think reading these as kind of a trifecta, you learn and understand better all sides of an argument. And what's kind of interesting is they all come to the same conclusion. So perhaps we're not all that different. Okay. We just spent a significant amount of time talking about personal healthcare finance. How do I, as a patient, use money, credit, and insurance to pay for healthcare services? But what about the other side? How do healthcare facilities and provider offices finance their operations? Well, they generate revenue, the cash that they earn, plus the promised cash in the form of accounts receivable, but the actual money that they have left to run operations and do everything they need to do, is the revenue minus inventory that they need to purchase, minus salary and benefits to their employees. You subtract the accounts receivable because that's not cash in your hand right now. That's a promise that someone will pay you. So all these insurance claims, I believe VUMC's um, uh, accounts receivable is in the realm of month to months. You don't get that payment next day when you are submitting something to insurance. Of course, organizations try to invest money, so that money disappears. You have to pay your liabilities, your creditors. But when you add that up with previous cash on hand, you hopefully have enough cash to keep yourself afloat, especially in the case of certain emergencies. And it is not uncommon, and it's in fact expected, that large academic centers would have about $1 billion to $2 billion of cash on hand, if not more. Healthcare offices get paid with a couple specific models of payment. You can get paid by appointment. You can get paid for an episode, paid for population of care, or through awards and donations. So let's touch on these a little bit more. Being paid by the appointment is also known as getting paid fee for service. That is an exchange of cash or credit right now for a service rendered today. So there are a little calendar with a circle around a single day. There's some trade-offs with fee for service. One is familiar. It's something that we all do all the time. You go to the grocery store, you pay for something right then and there, and you get it. And ideally, it responds to market forces. If someone isn't good at providing something, ideally, people stop going to that individual for care. But the trade-offs to this are that, well, there's not really a practical way to judge healthcare. I think you all have your choice and have tried different types of coffee. The coffee that's just in the office, McDonald's, Starbucks, even those fancy baristas where they French press everything. So you can judge the quality of the coffee, the price value for you, how quickly it's delivered to you, and make a judgment on what works for you and use and spend your dollars the way that you see fit. But how does HCA compare to VUMC in terms of efficiency of care delivery, quality of outcomes? Will you heal faster if you see a doctor at one place versus another? How about the service level? We really don't have a way of judging it. We look at star ratings on health grades, but that doesn't tell you if I'm a good doctor. It just tells you if people think I'm nice. Another trade-off for fee-for-service is that in healthcare, the seller selects the treatment that you get. So you don't actually pick what you want. I, by and large, tell you what the options are and often tell you what you're going to get. Even though 97% of healthcare services are provided when the person is able to consent, no greater than 50%, according to, I believe, one study out of Yale, of services are considered shoppable. Often there is a urgent pressing to do what the doctor says is right. But when things are shoppable, people don't actually shop. One study out of Yale saw that individuals who needed something like an MRI of their knee would typically go past 6 facilities that offered MRIs in order to go to the one that their provider set up for them. The other issue or another trade-off with fee-for-service is that you pay for complications. So if you come to see me for a procedure and I mess it up, you also pay me for me to fix my mistakes. The next model that healthcare offices and providers are paid through is pay for an episode. So an episode is if I do something, there's a period of time that everything related to that starting point is covered under. So surgery, you may have heard the term of a global period. Fracture management often falls under and does fall under a global period. Diagnosis-related groups. So if you are admitted into the hospital and you have Medicare, the inpatient prospective payment system uses something called DRG designations, so that based on the diagnosis that you are given and are discharged with, there is a specific payment that comes out and covers a 90-day period for that diagnosis, including hospital readmissions. And then there are different types of bundled care. Some care is direct to employer, where healthcare providers are going directly to employers and saying, hey, if you need care for this thing, we will take care of that whole episode for different employees at a bundled rate per employee. Certain trade-offs here. One, again, a payment for all related care is covered in one payment. It's correlated with less waste. So if you know you're getting a bundled amount, you may be more judicious about certain things you order. You may not just get an X-ray every time the patient comes in. You may not get an MRI every time the patient comes in, because that is maybe coming out of your own pockets as a provider, coming out of the provider and hospital's pockets. There's also the possibility that your profits can go up if you offer better quality and processes. For example, if you and I both do the same surgery, but you are much better at doing that surgery than I am, I may have more complications, and I may have more people coming back in because the closure wasn't good, or there's an infection in the incision. I am going to have to cover that by not getting paid for the visits and potentially for some of the supplies used in treatments provided. But an office that has a more skilled, technically skilled provider can hopefully create an opportunity where they have more profits because they have fewer mistakes. Some of the other trade-offs, unfortunately, because things are grouped together, cases that are easier on one side of the grouping spectrum versus cases that are harder, certain groups may try to only take on the easier cases. And we'll see that in an example later. So that may mean that certain patients are limited on which providers that will actually take care of them. You know, it's not uncommon for me to hear people say, well, I came up to you because another provider said there's nothing else that they could do for me. So in the case of payment for episodes, they may be saying, oh, I took care of it, or I don't want to even get into that episode where I'm probably going to, or where a healthcare office may end up needing to spend more because they predict certain patients may have more complications. It also can be considered boilerplate medicine. If the healthcare provider's office culture is not a strong one, people may think, oh, you just want us to enact new processes and follow new procedures for these episodes so that you can save money, but it takes the autonomy away from me as a provider to do what I think is best. If I want to order another MRI, I should be able to do so. So you have to be aware of that trade-off also. Another model used to pay healthcare offices is the pay-for-population model. This includes models like the 1990s health maintenance organizations, or HMOs, which were capitated. The organization was assigned a population of people, and they were at that time very motivated just to save money. Other capitation models, more modern ones, not only try to enact models or enact business practices that save money, but they are also trying to maximize quality. And a great example of that is Oak Street Health out of Chicago and Philadelphia. We'll talk a little bit more about them hopefully in a few moments. Another pay-for-population model is the alternative payment model out of Medicare. and an alternative payment model, specifically the Medicare shared savings model, assigns people to a healthcare group. So patients that use Vanderbilt, for example, if they primarily use Vanderbilt, those people are assigned to Vanderbilt kind of in the background. And if Vanderbilt is able to provide care in such a way that it meets certain quality metrics and cost metrics, the amount that is saved, predicted to how much was expected to be spent, a portion of that savings is delivered to the healthcare organization to which the patients are assigned. Okay. What are some of the, oh, no, we won't go into trade-offs just yet. I want to talk about how especially with the Medicare shared savings, how quality or value is measured there, some of those value metrics. 30% of the metric is based off of quality. So that is patients reporting better outcomes, fewer hospital readmissions, fewer hospital-acquired infections or conditions. 30% of the value modifiers based on something called resource use. So if you use more x-rays, greater use of MRIs, if you're doing excessive surgery or spending more time in the OR suite, patients under anesthesia for longer periods of time, you get knocked for that part of the shared savings calculation. Advancing care information is 20%, 25% of that adjustment. And if you are a group that uses EMR, that encourages patients to sign up for portals like My Health at Vanderbilt, that communicates with patients through patient messaging, then you get an extra little bump to this modifier. And 15% of the modifier is something called performance improvement, which I misspelled there. I apologize for that. And that is related to how patients report you do on surveys and how quickly patients who schedule are seen. So when you hear about your departments really pushing to get people seen within 14 days, that is based on the performance improvement modifier that influences how hospitals and healthcare providers get paid, specifically when they see Medicare patients. One little note, although this is specific to a modifier used for Medicare payments, they don't just measure Medicare patients' outcomes. They look at your use for all your patients. So you have to treat everyone well in order for Medicare to give you this bonus bump. So some of the trade-offs for being paid for by population, it's correlated with less waste. Large numbers of people can get enrolled, hopefully leaving fewer people uncovered. There is opportunity for competition. So that quality modifier, you can get bumped up, you can get bumped down. And it's based on your comparison to other groups, not just based on your comparison in the past. So if you're one of the better groups, you can make up to, I believe, 21% more each year from your Medicare payments. And if you're on the low side, I believe you can be knocked as much as 9%. So there's competition between groups that see Medicare patients, like academic medical centers in this area, or St. Thomas versus HCA versus VUMC. We're all competing for that extra value bump. And there are also opportunities for creative healthcare groups to cultivate some novel socioeconomic solutions. Because you are paid for population kind of on the front end, you have this larger lump of money to begin with. And groups like Oak Street Health out of Philadelphia and Chicago do all types of amazing things, and other groups do too. For example, they will fund community events. They will, different groups may provide lunches or to kids in school. They may take food to the elderly. They may drive people to their appointments. Groups like there's a health system out of Pennsylvania. The name is escaping me right now. And they actually have something called the pharmacy, which is FARMC. So what they do is they offer fresh foods, and patients can actually get their groceries from the healthcare system. Things like things like these are novel approaches to address healthcare issues more at the root, and not just react when a healthcare issue comes into the office. So that's a really neat positive trade-off to this approach. Some of the other side, more negative trade-offs, that a healthcare access can be limited just to the networks that the population is assigned to, especially for capitated groups. With larger populations being seen, sometimes physicians and providers are known to spend less time with patients because they're trying to rush through, because they've taken on so many enrollees that they have to shorten their appointment times, which may reduce quality scores. And of course, there's a risk, especially there's a risk that money may run out. Ultimately, if you pay for great quality and everyone starts doing better quality, you may start reducing the amount that you incentivize people by year over year. So that is a risk. There's also a model, not the primary model for academic centers like BUMC, but many, especially community-based healthcare offices, rely on donations and awards. And for academic centers, large academic centers, it is not uncommon to hear about grants, grant funding being over $500 million per year, and philanthropy being over $50 million per year. Although revenue can be generated through fee-for-service, through episodes, or through the management of populations, there's also a significant amount that comes from donations and awards. Okay. All right. So now we've spoken about how individuals manage healthcare finances personally, through having enough cash, through potentially using credit, potentially using insurance, and how on the side we discussed how insurance, as it's currently constituted, may unfortunately encourage healthcare prices to go up, making it harder for patients to manage their finances. We also spoke about how healthcare organizations manage their finances, specifically how they get paid, and through the different models there. So now I want to go into 3 cases that go through scenarios of patients needing healthcare services and how the finances are managed. The first case will be a woman with, we'll say a middle-aged woman with chronic elbow pain. And this patient has come to see me now for quite a number of months, diagnosed with tennis elbow or lateral epicondylitis, and we tried bracing and we tried occupational therapy. I like to avoid steroid injections here, but some people use steroid injections. Unfortunately, this individual has continued to have these symptoms. So we are now discussing a treatment called percutaneous ultrasonic tenotomy to help address this. And I talk about how successful it is at relieving pain. We like to avoid using it to begin with because it is a little more invasive and potentially more expensive, but we will get this all set up for you. And I think you're going to be back to playing tennis very soon. But wait, doc, you just said it may be expensive. Well, how much does it cost? Well, for this patient who has private insurance and is being seen as an outpatient, how much does it cost for them? All right. So I know what procedures I do. And these are the CPT codes for that procedure. And there are surgical center fees, facility fees, and those aren't technically called CPT codes. So I don't know if there's a code number for it, but do we know what the charges are? And for me, I actually personally do. I've made it a point to find out what my charges are. So as of the end of 2019, these are the charges for that procedure. Okay, if we add all of those up, I could tell the patient what that amount is. And they may say, all right, so that's how much it's going to cost me. And I'd say, no, well, that's the out of pocket. That is the most expensive that it would be. Well, I have insurance, doc. How much is it then? So then we go through a process. As we're going to apply this patient's insurance benefits, we have to go through authorization, a prior authorization, an authorization done before the procedure is performed. And if this is authorized, which can take 14 days, then the insurance benefits will be applied. A lot of people think of insurance benefits as insurance paying for it, but I like to think of it at first as a discount. Think of it as a coupon. Insurance has negotiated a different rate. Where it may cost $100, insurance has negotiated $90. You get a $10 coupon. Once it is approved through that authorization process, it is important for people to realize approved does not mean it is paid for. A lot of people believe that's the case because our expectation for insurance is that it covers everything. But authorization does not mean that it is paid for. It means you get the discount. So how much out of pocket would this individual expect to pay? And to find that out, the best place to call is actually to call your insurance provider. But Vanderbilt also wants to make wants to be helpful in providing patients with an opportunity to find out their estimate of out-of-pocket costs by calling a number I'll put up on the screen in just a second. So in visual form, you have a charge for a service. Your insurance adjustment, the negotiated rate, is essentially just a discount off. And after that is done, the amount you actually pay is going to be based on your remaining deductible, and what's left is paid for through coinsurance, which if you have a 100-0 coinsurance, that means your insurance company is going to pay the full coinsurance and anything that's left over. But if you have something like an 80-20, you, after paying your remaining deductible, will be responsible for 20% of what's left over up to whatever the coinsurance covers. Sometimes after that, anything that's left over the insurance will pay. You really need to find out what your insurance covers and how it's structured. What is your premium, the amount you pay every month in? What is your deductible, the amount you pay before insurance starts applying any payment? You need to know what the coinsurance is, both the total amount that would go under coinsurance and your proportion of the coinsurance. And if there is a clause where the insurance company will take care of anything after that. And of course, with any procedure, if you call in, you need the codes in order to find out what the expected charges are even going to be and what the negotiated rates are, because the deductible, coinsurance, and everything else is based off of those negotiated rates. So at the end of the day, you pay a certain amount, which I have depicted here in blue, and the insurance would pay the remainder in green. Always remember, the insurance only has that money because you and everyone else who uses that insurance pays premiums in. So ultimately, it is all coming from you. Okay. So things that you can do. Know your charges. As a med student, you're not going to find out what the charges are. and it's not really appropriate for you to share that. Perhaps encouraging your attendings to be aware of their charges and having them share that information. But when you are a licensed provider, know what your charges are. I think it's important to share that with individuals so no one is surprised. I think it's important to know what your CPT codes are. That way you can share that with patients and they can find out through their insurance company what their expected out-of-pocket will be. If you are at VUMC and patients would like to call the VUMC estimate line, this is the number for that, 615-936-6639. Okay. Case 2, degenerative scoliosis. So this is a individual who is over the age of 65, is on Medicare, uses Medicare as her primary and sole insurance. She has had chronic back pain associated with degenerative scoliosis and lumbar degenerative disc disease. Conservative treatments have not affected her symptoms effectively, and she is hoping for relief through surgery, fusion of the lumbar spine. This is an inpatient procedure, and being that she is a Medicare recipient, would fall under that DRG episode payment. Okay, so the professional charges for the surgeries that make up the procedures that are components of the surgery include some items listed here. The charges listed, since I don't do these surgeries, I don't know these charges for me personally, but these are ranges that reflect the usual, customary, and reasonable charges that are seen across the country. So in different parts of the country, you'll have charges for these different components of the surgery of this amount. The professional reimbursement is paid for through Medicare, almost like a fee-for-service model. But what about the hospital charges? You know, to use the surgical suite or the inpatient room, the medications while you were there. What about after the fact? You may go to a skilled nursing facility, use physical therapy, and then the medications from your pharmacy when you go home. Well, from the hospital standpoint, these payments all go under that DRG system. The hospital, not the providers, but the hospital itself has a payment that is based off of the final diagnosis. There is one primary diagnosis and then other diagnoses that may be addressed while the patient is in the hospital can all be used to, or all influence the final DRG grouping. So, for example, someone with degenerative scoliosis may have, after discharge, they may be assigned to the DRG 459 group, which is spine surgery, not including cervical, with major comorbidities and complications, I believe. And the payment for that is listed below. Those payments are the average payments reported in 2020 across the US. The DRG 460 is spine surgery, not including cervical, without major complication or comorbidity. And the ranges of payment across the country are listed here. Now, you may notice that there's a difference between the two, and that goes into the conditions that the patients had when they were when they came in for surgery. The higher the comorbidities and morbidity risk, the more likely you're going to be bumped into that higher DRG group. But look at the spread here in terms of payment. Why is there such a spread? Well, that spread is based on your DRG payment. Now, across the country, there is a labor portion. Now, that gets modified some by where you live, a wage index where if you live in New York, the wage index is going to be greater than if you live in rural Alabama, for example. But that product becomes the labor portion. And then there's a non-labor portion for supplies and things like that. And together, the labor portion with wage index and the non-labor portion when put together becomes kind of this initial number. Based on the DRG that the patient is placed in, there is a multiplier associated with that. And that multiplier plus the base number become the base payment when multiplied together. That base payment can still fluctuate quite a bit across the country. The base payment increases if you're an academic center and you meet certain GME qualifications. Based on your graduate medical education work, you can receive different levels of GME bonus. If you see a disproportionate share of patients on Medicaid, there's a bonus associated with that. If you meet certain qualifications on and certain metrics on hospital readmission rates, there's a bonus or a subtraction associated with that. And there are value-based payments based on other value quantities that we discussed earlier, the quality score, resource use, advancing care information, and professional improvement. So all those things go into how your base payment gets modified, these different items that are added or subtracted away from your base payment. So that is what creates this range within certain DRGs. But there is a potential flaw or issue with these with the DRG system, and that's that it may be very broad. Lumbar surgery, not including cervical, well, that can include a single level fusion or a 7-level fusion. And one group out of New Jersey, I believe, in 2020 produced a study looking at the variance in costs, not the price, but how much does it cost for a hospital to provide care that fits into these DRGs, and what characteristics of the patients that were that fell into that DRG grouping was associated with more or less cost. And if patients had, as noted here, history of stroke, Parkinson's, coagulopathy, if there was fusion of greater than 3 levels, if there was an interbody device to help reduce pressure over nerves and radicular or neuropathic symptoms, those were more expensive things to provide, but the DRG payment didn't change. So hospitals have to be very aware of that financing. So what are certain things that you can do to help ensure that there is balanced and fair exchange of money and credit for services and goods that are rendered? Well, code all pertinent diagnoses. If someone comes in and they're coming in for an inpatient procedure like a lumbar fusion, but they have uncontrolled type 2 diabetes, or they have hypertension or coagulopathy, those are all things that need to be addressed. You may be asking, well, would you do a surgery if someone had uncontrolled issues? Well, if there's an emergent need for it, like fractures or major trauma, compression on nerves from neoplasms, for example, those would be times where you may move forward with a procedure in a less than ideal candidate. So getting back to the main point, code all the diagnoses and code and document how you care for those diagnoses, even if it's continuing with previous care plan. That is all important because that helps determine which DRG group a patient is going to be grouped in. It also, in my opinion, helps improve your quality. If you're aware that you're taking care of all these items, you're more likely to, in my opinion, take care of those things well and have fewer opportunities for adverse events. It is not uncommon with these long medication lists and these long problem lists that patients have to accidentally not read everything because you may be focused on your one primary diagnosis. But if you're thinking about all of them, kind of like an ICU provider does, you're less likely to make those medical errors. The other reason, something else that you can do is learn your hospital's quality indicators. For example, in our hospital, like most, we look at readmission rates, but we also look at something called ODE, observed versus expected adverse events. So if you are below and observe a lower number of adverse events than what is expected for certain DRGs, that goes into your quality score. So we document that, and currently cardiac surgery and I believe cardiology have implemented certain phrases and keywords into Epic so that they can, within their note, appropriately indicate all the diagnoses that they're treating and also indicate different things that impact the searchability of ODE information. If you want more information on this, especially as you become faculty, if you're become faculty here, you will meet Ms. Stephanie Hayes and Kathy Cohen, who will teach you all the things that we need to know about coding. And if you are interested in learning about those things now as a student so that you can take that information and just refresh members of the inpatient and outpatient teams, you can reach out to those individuals as well. The third case is a forearm fracture. Okay, so this young buck unfortunately had a forearm fracture and is uninsured. And they showed up to the emergency department for care, where they are going to receive a closed reduction. The codes and charges here are actually the codes if someone were to see me in the clinic as an outpatient, but as an outpatient, the insurance has already been verified before. In the emergency room, that isn't necessarily going to be the case. So we'll use these charges as if these were my charges in the ED. I don't visit the emergency department, so I don't have those charges personally. But if we add all of this up together, we have just over $3,000 in charges. And the last one, that fracture care charge, initiates an episode. So this is payment for a 90-day episode. Now, let's not forget one of those graphs that we saw earlier. $3,000 out of pocket is not, it's not small. And the majority of individuals don't have that amount available. And although the numbers don't come down exactly at the $3,000 mark like this case does, when looking at those previous numbers from that Yahoo Finance report, only 20, maybe just a small amount more than 20% of American households would be able to pay this if they were uninsured. So there is a large proportion of our country that if uninsured, this would really be detrimental and hurt their personal finances. So how about at academic centers? How much care is provided that is uninsured? And for large academic centers per year, it comes out to about $25 million for many places. That is perhaps a little smaller than you first considered. Perhaps it's larger. I guess it all depends on how frequently you get a chance to look at the hospital's accounting. Just so you know, VUMC is nonprofit, so you can always take a look at the tax returns online. They are publicly posted, so you can compare the 25 million compared to the actual receipts and income of VUMC. I'll save that adventure for you. Now, academic centers like ours really only expect a certain percentage of reimbursement from groups like Medicaid, expecting, I believe, 27% or so. So although 25 million in charges are posted, only maybe posted, a group like VUMC would only expect back just under 7 million in payment. So how much is collected? I want you to be very, very careful here. I believe many people assume that the bad debt, the debt that's written off, is attributed or comes from uninsured individuals. That is not true. It comes from all individuals. So insured or not, people often try to avoid paying what they're responsible to pay. But I don't know, and I don't know anyone here at VUMC who is able to tell me how much typically, what proportion typically gets collected from the uninsured. So it may be that 25 million in charges goes out as $25 million billed, and the uninsured that visit healthcare centers like ours pay $25 million on it instead of the expected 6.75 million that Medicaid would have paid. So I don't know how much gets collected, but still, when someone is not insured, to try and lessen the possibility that they would have a huge negative impact on their personal finances, we often try to get them set up for services like Medicaid. So if you have a patient that is uninsured that you are seeing in the emergency department, you can reach out to the Director of Admitting, Ms. Marcia Kedig, to work on helping set that person up with Medicaid while they are at the facility. Now, it may be done after the fact, but it gets the ball rolling. If you are seeing someone who is uninsured as an outpatient, maybe they walk in and the front desk gets them set up for an appointment, and later it's found out that their insurance lapsed. Financial counseling can be provided through this VUMC hotline. So please utilize those, especially that last one, if someone is receiving care and is uninsured when they receive it and is getting a bill that is difficult for them to manage. Excellent. So that is the presentation. Hopefully you found that a helpful review of how a person's personal finances, cash, credit, insurance, helps them transact with healthcare providers, and a helpful review of how medical offices and providers get paid through different models, including getting paid for appointment, episodes, populations, or earning money through donations and awards, and how through some specific cases those worlds intertwine, and how you as a student and a future physician can use different resources to prepare everyone and make sure that people can pay and that people get paid. All right, that's it. If you guys have any questions, send me emails. Hopefully y'all enjoy. Have a great one.